Good evening and a very warm welcome to everyone. I hope you and your loved ones are safe. We welcome you all to the second discussion of this virtual, scientific, and educative knowledge series curated by the Organization of Pharmaceutical Producers of India, OPPI, in collaboration with International Alliance of Patients Organization, NatHealth, the Indian Pharmaceutical Association, and SearPharm Forum. These five associations have joined hands to support the Indian central and state government efforts to ensure dissemination of correct and factual information on COVID-19 and to encourage people to get vaccinated upon their turn. Our campaign, No One is Safe Until Everyone is Safe, was launched on June 14th, and this knowledge series is an extension of the same. India has successfully overcome the second wave of COVID-19 and has a massive vaccine program already rolled out. However, one of the main problems the country faces today is on vaccine hesitancy. The hesitancy is driven by myths on the possible side effects and the lack of access to accurate information. It's important, therefore, to build vaccine confidence by instilling faith in the protective nature of the vaccine and the benefits of having a much milder disease outcome should the person be infected. The objective of today's panel discussion is to declutter any misinformation on such possible side effects of the vaccine and to educate the general public on how vaccines are the proven and the scientific way to fight any virus. Without much ado, then, let me introduce our panel. We have with us today Dr. Raj Shankar Ghosh, Senior Advisor, Vaccine Delivery, Bill and Melinda Gates Foundation. Dr. Raj Shankar is a public health physician with 30 years of experience in primary healthcare and infectious diseases. Prior to joining the Gates Foundation, he was Director, Regional Vaccine Delivery Path of work of PATH in South Asia and Western Pacific region, focusing on new vaccine introductions. He has also served as regional coordinator of National Polio Surveillance Project of WHO in India. He is an honorary fellow of Indian Public Health Association. Thank you, Dr. Raj. Our second panelist today is Ms. Priti Sudan, former Union Health Secretary, member of the Indian Independent Panel for Pandemic Preparedness and Response. Ms. Sudan has been an IAS officer of the 1983 batch from Andhra Pradesh, Kedah. She retired as Secretary, Ministry of Health and Family Welfare, Government of India, on 31st July 2020, after nearly 3 fruitful and successful years, especially the last 6 months during which she was at the forefront of tackling the COVID-19 pandemic. Amongst her notable contributions to policy have been initiating and implementing 2 major flagship programs of the country, Beti Bachao, Beti Padhao, and Ayushman Bharat, besides legislations on National Medical Commission, allied health professional, and ban of e-cigarettes. Thank you, Madam Sudan. Our third panelist is Dr. Anant Bhan. Dr. Bhan is a physician with a master's degree in bioethics from the University of Toronto and a researcher in global health, bioethics, and health policy. He is the adjunct professor at Yenepoya University, Mangaluru, and the adjunct faculty at Kasturba Medical College in Manipal. Dr. Bhan is immediate past president, International Association of Bioethics. His work focuses on ethics and equity in health, mental health, digital health, public health ethics, research ethics, community engagement, ethics of innovative technologies, and ethics training for professionals. Welcome, Dr. Bhan. The panel is being moderated by Dr. Ratna Devi, Chair of the Board of Trustees at IAPO, founding member IPAG, CEO Dakshayani and Amravati Health and Education. A medical doctor, public health and management professional, Dr. Ratna has over 30 years of experience working to improve health outcomes in India, working with the government and national and international NGOs on donor-funded public health initiatives. She leads the Indian Alliance of Patient Groups and is a founding board member of Healthy India Alliance, advisory board member of IORD, and founding member Asia Pacific Alliance of Rare Disease Organizations. She serves as a WHO expert for NCDs, rare diseases, and patient safety, and heads the Patient Academy for Innovation and Research. A warm welcome to you all. I now hand it over to our moderator, Dr. Ratna Devi, to set the context for today's discussion. Thank you, and over to you, Dr. Ratna.
Thank you, Savri, for setting the context, and a very, very warm welcome to all our panelists. As our audience can see, we have a stellar, panel before us who can really throw a lot of light on bursting myths around vaccine hesitancy as the topic for today is. India, as you know, is a very, very large country. Anything that happens in India cannot be small. It is big. And so are our problems, whether it is getting all the people vaccinated or managing the pandemic through the first and the second waves. But we have always been successful. We have great minds. We have great scientific experts. We have great policymakers, and India has been very, very proactive in managing both the first and the second waves of the pandemic. While we are already preparing for a possible third wave, and there is real-time alerts which tell how people can be prepared, what they should do in terms of appropriate behaviors to protect themselves, and how they can go to the nearest hospital. So there is real-time data that is available that helps people to be able to protect themselves and keep themselves healthy. So coming to some statistics, based on the 2011 census data for India, some 90 crores to 95 crores or 900 to 950 million people are 18 years and above. And if you see our protocols, then all people above 18 years are eligible for vaccination. So far, if you see the people who are fully vaccinated with 2 doses, it's around 10%, which is about 9.98 crores or roughly 10 crores. However, we have seen a huge positive trend after the second wave, which with a big impetus, and therefore we have nearly 35 crores people vaccinated with the first dose. So there are three pillars that drive this whole vaccination, and that is awareness, access, and then all these apprehensions and myths and misconceptions that make people hesitant towards the vaccination. In terms of awareness, we have the Arogya Setu app, which gives you lots of information on people around you who could be at risk, what you should do if you are positive, how can you, contact people. There are helplines that you can actually dial into for your information. There is a helpline that is dedicated for mental health, so that people who are stressed out can actually reach out. You have the CoWIN app where you can book your appointments, you can download your certificates, and a host of other information, including videos from people who are public figures and who give messages, who give out positive messages so that people can actually build confidence around the vaccination. In terms of access, you have a public-private mix with a huge number of government hospitals providing these vaccines free of cost. There is also a lot of private sector initiatives that are happening. In terms of apprehension, and this is what we are going to address today, hopefully through our discussion, is that in spite of all these positive efforts that are happening from various sectors, including the government, the private sector, the corporate, etc., you still see a lot of people not turning up for vaccination. And just to give you an example, the Resident Welfare Association in the condominium where I stay, which is considered to be a literate, society, organized a vaccination camp for its residents in partnership with the primary health center that is close by. And the staff came with 200 doses, and only 62 people turned up for the vaccine. So it is at your doorstep, yet people are not turning up. You also see media reports where corporate is helping by vaccinating its employees. So I got a message from Uber saying 100,000 drivers have been vaccinated. However, if you go deeper, you see that about 20 to 30% of those drivers didn't turn up, even though Uber made an effort to vaccinate them. You see these in several corporate areas where Flipkart or Amazon, everyone who has frontline workers is making that extra effort to vaccinate people, but people are not turning up, even though it's free of cost and everything is being provided. Similar stories are also emerging from rural India, where you see frontline workers are not being welcome. So when they go and give information about vaccine or ask people to book appointments, they are turned away, and they are not, being welcomed in rural India as well. So what is it that is driving people away from this vaccination? Why is this hesitancy? And I think there are several factors that is contributing to this. One is, of course, several media reports that you hear. One such report that caught my attention just a few days back is a Mumbai doctor was, tested positive 3 times within the last 18 months and twice after vaccination. And even educated people, this seeds, a small seed of doubt is germinated. Is the vaccine really protecting me? So a lot of such media reports, lots of messages on WhatsApp and other social media that actually create this hesitancy. So without much ado, I will call on Dr. Rajshankar Ghosh as my first speaker. And Dr. Ghosh, you have had a huge experience on childhood vaccination, and we have bounced back, even though we had this slight fallback in vaccination rates during lockdown. We have bounced back to better than levels than before the lockdown. So what are some of the learnings that we have from this childhood vaccination in terms of the strengths that it has, and what kind of learnings can then be brought to adult vaccination, and how can we then dispel some of these myths and misconceptions and achieve the targets that we have set out as a country? Over to you, Dr. Ghosh.
Thank you. Thank you very much, Dr. Ratna Devi. Can we have the slides, please? So what we will talk about today is primarily addressing vaccine hesitancy in India, Vigyan, Vachan, and Vishwas ke Drishtikon se, through the lens of science, commitment, and trust. Can you get the next slide, please? Or is it possible for me to take control, actually? Yeah. So basically, setting a context to the conversation, what we will discuss today is what have we learned of vaccine hesitance in India from the past vaccination campaigns. India, as you know, has been having large vaccination campaigns since 1995 with the pulse polio immunization. And then after that, Mission Indradhanush, intensified Mission Indradhanush. India has one of the best experiences of conducting large vaccination campaigns, also the Japanese encephalitis vaccination campaigns. The second part that we will talk a little bit about is the science behind COVID vaccines in India, the safety, effectiveness, and the supply. And I just wanted to caution that whatever I'll be speaking today is from public information, whatever is out there from the government and from trusted public sources, and that I will be speaking to you about, and a little bit of some of the take-home messages that we wanted you to go back with. Next slide, please. So before we get into vaccine hesitancy, I just wanted to touch upon effective vaccination. What do we mean by effective vaccination? Effective vaccination is a play of 3 Ps, product, place, and people. Effective vaccination is an uninterrupted availability of safe, efficacious, and affordable vaccines at a place that is accessible and acceptable to the community, where trained health workers deliver vaccines to people who are aware and informed of the vaccines which they or their dependents will receive. There are a few stimuli that we have seen in the program which result in vaccine hesitancy. One of them is interrupted vaccine supply. One of my uncles in Calcutta actually had to go to a center twice, and he was refused because either the vaccination center did not have the vaccine, and on the second occasion, there were so many people crowding in that center that my 80-year-old uncle actually felt unsafe and to come back. And he was very hesitant to go for the third time. The second issue that is there is around the inability to access vaccination sessions and sites, which we hear of, in the rural area a lot in the initial days when the difficulty through registration through the CoWIN portal happened. And now, there are walk-in and all of those things that have been brought in. But initially, there was a lot of hesitancy in terms of registration. The third is around the lack of awareness of the program and the product. People did not understand which vaccine to go for. People were waiting for better vaccines to come in the pipeline, and therefore they wanted to wait and not take the vaccine that was available. And finally, a delayed and misreporting of adverse events following immunization, particularly from the peers, from neighbors, from media, led to a lot of vaccine hesitancy in the program. Next slide, please. So therefore, some of the lessons from polio and MR campaigns, and these are my personal lessons when I sort of worked in Muradabad and mirror districts of Uttar Pradesh, also in West Bengal and Bihar and South India. There are primarily 5 questions that people had. One, was that because I know that the vaccine is not good, because I know that the vaccine is going to cause harm to my child. Therefore, I will not take the vaccine, or I will not allow my child to take the vaccine. This was awareness, apprehension, and lack of confidence. The second one was what a group of people who were not sure. They always said that, I don't know, but I have heard from my neighbor or from some source that the vaccine is not good, the vaccine causes these problems, and these were primarily awareness and apprehension issues. The third one was because I want. Their priorities were different. This was particularly, I remember we went to a village in Malda district of West Bengal, where they said that, we don't care about the vaccine. We don't have roads. We don't have a hospital where there is a doctor in our village or in nearby villages. Therefore, first, what I want is the hospital and the road. And then you come and talk to me about the vaccine. Therefore, because I want a hospital, I'm not going to take the vaccine because, I want to hold you kind of to ransom that you build the hospital, then I'll take the vaccine. The fourth is that because I cannot. These were primarily daily wage laborers. These were primarily people who used to board trains, early in the morning at 6 o'clock and come back at 8 o'clock. And many of them do so from rural parts of Bengal, Uttar Pradesh, Bihar. And they said that, the timing is completely not, suitable for us to really take our children to get vaccinated. You hold a camp after 8 o'clock in the evening, we'll take our children. And finally, because I will not. This was a particular thing that we saw during the measles vaccination in South India. In Tamil Nadu, I faced this, and in UP, I faced this. Actually, I faced this in Bhopal also, where children were vaccinated in the school, and the parents were not informed about the MR vaccination, and therefore parents were angry. Parents said that we will not allow vaccination without a consent from us about our children. Therefore, we will not vaccinate because the process that is being followed is unethical. The process that is being followed is not, with our consent. Therefore, we will not vaccinate. So these were the kinds of, statements that we heard from the parents and the people. Now, how did we address it? I saw this very good application in Madhya Pradesh, actually in Bhopal. The state OPPI officer is a great communicator. So he kind of, developed these 4P planning, which was to learn patiently, which means that hear them, learn patiently about what they are trying to say. They might be saying something, but at the back of their mind, they have another problem. Try to understand that. The second is, it's not a one-time affair that you go and tell them and you come back and you sit quietly. It's not going to happen that way. You need to persuade. You need to keep on, reaching out to them. You need to keep on talking to them. The dialogue must go on. The third is that do not act as a giver and them as a recipient. It's a partnership. It's a partnership between the health system and the community. And that partnership must be in a way which benefits everyone, which benefits each of these groups, the community, the system, the providers, all of them. And finally, it requires a lot of planning. It just doesn't happen overnight. In order to overcome the resistance, to overcome the hesitancy, it is a huge planning process that takes place. And it's not only up to the health workers, but it's up to the social workers. It is up to the education department. It's up to the local representatives who must all come together. And most importantly, the parents must be included in the planning in order for the vaccination program to happen. Can you go to the next slide, please? Let's come at the COVID vaccination program update. This is up to July 26, and Dr. Ratnadevi already spoke about this. We have a 940 million target. We had 435 million vaccinated till that day. Today, we have reached 450 million. I just saw the report. Fully immunized, we have around 93.4 million till 26/7. That's around 10%. And we will need to vaccinate around 9.2 million every day in order to achieve a full immunization by December 31st that the government of India has set as a goal for the country. Next slide, please. I just wanted to give a little bit update on the 3 vaccines that we are using in India, and this is all from the public source. The links are there. The Covishield has been approved in 119 countries to be used. Covaxin has been approved in 9 countries, and Sputnik has been approved in 70 countries. The number vaccinated till 26 July is around 389 million with Covishield, 53 million with Covaxin, and Sputnik was around 400,000. Next slide, please. In terms of supply, and this again is the public information, comes from what the presentation at the Parliament was by the Health Minister, that the current capacity of Covishield is around 110 million, Covaxin is around 25 million, and Sputnik is a limited supply. The projected capacity, and I'm sure that we are going by a little bit of a conservative approach here, given that we have somewhere previously made some kind of erroneous projections. 120 million for Covishield, 58 million for Covaxin, and again this comes from the report that was placed in the Parliament. Therefore, we do see that there will be interrupted product if we are to really scale up to a level of around 9.5 million per day that we were targeting. Therefore, we will need other vaccines in the pipeline in order to boost the program. Can we move to the next slide? I just wanted to, briefly touch upon, the safety surveillance, which is the adverse events following immunization program surveillance process in India. There are 3 kinds of surveillance reports that are, generally registered: the minor events, the severe events, and the serious events. And these are registered by the vaccinators and the doctors in the COVID software. The analysis that we look at is around the trend of the diseases, the causality assessment, the linking of the event with the vaccine, whether it was caused by the vaccine, and this is looked upon in various stages in terms of the causality assessment. And the third part is that there are state and national adverse events following immunization committees of experts who look at all the data and then come up with the idea about whether this is caused by the vaccine or not caused by the vaccine. The monitoring of the entire surveillance is by AFI committees, who are independent experts, clinicians, immunologists, epidemiologists. And compared with global database, clinical trial data for new events is looked upon. And very recently, we have started looking at new events which are assessed completely separately. These are things like thrombosis and thrombocytopenic syndromes, the Guillain-Barré syndrome, anaphylaxis. All of these are separately looked at as adverse event of special interest. The next slide, please. Okay, so one of the things that is stressed from the government of India is in order to improve this surveillance so that we can reach global standards in terms of the capturing the data. Special studies, as I said, is in regular process. There's a continuous process which requires coordination with the drug regulators, the Drug Controller General of India, the immunization teams at the state and district levels, and the pharmacovigilance system in medical college and hospital. And also India is talking to various other countries, particularly to UK and to US and to other European nations, in order to understand the occurrence of the adverse events in their countries and matching them with what we are seeing in our country. Next slide, please. In terms of vaccine safety, sorry for the busy slide. I just wanted to say that the adverse event following immunization data, and this is again from the government public website, is that in India, we see that there is a very minuscule but definitive risk of thromboembolic events, which have been seen in other countries like UK and Germany. The reporting of these events in India is around 0.61 per million doses, which is much lower than the 4 cases per million reported by UK's regulator, Medical and Health Regulatory Authority. And Germany has reported around 10 events per million. We will have to see whether the robustness of the surveillance is actually able to capture all the diseases or all the events. There is a constant effort to improve that surveillance. But however, as of today, with the existing surveillance, this is what the Government of India's report is on their websites. Can you go to the next slide? On the vaccine effectiveness, we have a very recent study which has come from the Indian Armed Forces, and this was a very meticulously designed and conducted with Covishield, which is the vaccine which is manufactured at Serum Institute of India. And we have seen from that study that it reduces the risk of breakthrough infections, which means having a COVID infection after a full dose of vaccination by around 91 to 94%. And secondly, recently the phase 3 clinical trial data of Covaxin was, which has been developed by ICMR and Bharat Biotech, has been published, and it shows around 81% efficacy. The results have been evaluated by an independent data safety and monitoring board. Can we go to the next slide, please? I wanted to leave you with some of the take-home messages. The best vaccine policy is that which factors human behaviors as a principal driver. No vaccine policy can ever happen if we do not really take the people's voice into making that policy. It is the interpretation of data that matters. Data can be interpreted in multiple ways. We have seen the multiple studies that have come up at multiple times and multiple interpretations, which are quite confusing actually to a layman and also to scientists. Therefore, I would say that data needs to be told in the common person's language that citizens can understand, visualize, and relate to. Thirdly, whether we will win the battle against the virus will be determined by our adherence to 3 S's: share, science, and society. Share meaning sharing of the vaccine. There are hoarding of vaccines by multiple countries who really need to share the vaccines with everyone in the globe so that everyone has an opportunity to get the vaccine. Science, we all understand that we need to design our program on scientific principles. And society, by society, I mean that we must stand by each other, give each other the right message, hold each other's hand, and ensure that the country is fully vaccinated so that we can be protected from any COVID infection in the future. And we must remember that no one is safe unless everyone is safe. Next slide, please. Thank you. These are the COVID-19 appropriate behaviors that we all want to remember, because vaccines alone will not be able to really make us victorious in this battle. We must adopt COVID-19 appropriate behaviors along with our vaccination in order to win this battle. Thank you very much.
Thank you, Dr. Ghosh, and excellent take-home messages that you gave us about no policy being effective if the patient's voice or the people's voice is not there right from the very beginning, from the design to the delivery stage. Also, you highlighted on why vaccine hesitancy is there because of lack of confidence, appropriate timings for vaccination not being there, a lack of confidence because the information is incomplete, even ethical issues where maybe appropriate consent was not taken, and all these issues need to be addressed if we have to increase the numbers, subject to, of course,
everything else. And the supply needs to be remembered that, we need to have a continuous supply in order to really motivate the people.
Exactly. And of course, I like this whole issue that you highlighted about partnerships, planning, and patience. You need to have the patience to receive the feedback so that you can strengthen the program based on the feedback. So without much ado, I would like to invite our next speaker, Madam Priti Sudan. Madam has been at the helm of one of the largest healthcare programs, considering the size and the population of our country. She comes with rich experience of having led a lot of programs where integration was important, and coming from some of the challenges that Dr. Ghosh has highlighted from the grassroots level. Ma'am, how do you see this from the policy perspective? We know that this whole entire vaccination program is a vertical and is addressing the adult population or 18+ population, whereas a lot of our people are already visiting hospitals, visiting other healthcare centers, etc. So is this vertical the right approach? In terms of the policy perspective, we already have some very strong pillars and initiatives from the government. How can we further strengthen this, and how can we make these numbers, a reality in the time frame that the government has set for itself? Over to you, ma'am.
Thank you, and thank you for having me here. I agree with what Dr. Ghosh presented, and thank you for such an effective presentation. I'd like to start where he left. He spoke about hoarding of vaccine by some countries, by the better off countries. And since I was part of the independent panel for pandemic preparedness and response, let me share with you the figures. See, the Western countries have pre-ordered 4.3 billion doses for 1.7 billion of their population. So even if you take two doses for each of the for all their entire population, you have 2 billion doses surplus. And as he said, no one is safe till all of us are safe. So I think high time that everybody acknowledges, understands, and acts in a manner that health is a global good. And vaccines, especially at this point of time, with COVID surging all over, with mutations happening, and we don't find a respite despite our best, we must realize that, and the better off nations have to actually now share their surplus doses at least. So thanks for pointing that out, Dr. Ghosh, a very relevant point. And as he also said that India has covered close to yesterday's figures, I quote, 456 million with COVID vaccinations. And let me tell you, it is a landmark. Again, I have seen from global perspective how lucky we are to be in India. There are countries in Africa, in South America, they don't have vaccines. They are dependent on donations. They are dependent on COVAX at all, which itself doesn't have enough of them, as I told you. So therefore, we are producing two vaccines on our own. Also, we have Sputnik is also, though, as he pointed out, the supply is a little uncertain. The numbers are uncertain, but yes, we've taken that step. And I think the government was very bold to pre-order a vaccine with biological E also, which will be, again, our own vaccine. So a lot of proactiveness has been shown by the government, and I think that should bear fruit very soon. And as I said, that 456 million COVID vaccinations we've done, it has been possible with only because of the clear guidance from the center, the hard work put in by the states, the UTs, our doctors, nurses, frontline workers, many unnamed who have quietly worked towards this, our scientists. And this, of course, was possible due to the enterprise and strength of our vaccine manufacturers who are represented in this August group. Now, as all countries strive to end the pandemic, it's quite interesting that it was in 2019, before the pandemic struck, that WHO described vaccine hesitancy as one of the 10 top threats to global health. They said that the issue threatened to reverse the progress made in tackling preventable diseases. So vaccine hesitancy is not a new phenomena. In immunization program, and Dr. Ghosh very, I think, eloquently elaborated this also, but it's important to understand what it is. It is the awareness gap. It is fear of adverse reaction, as he also pointed out. Then sometimes the influencers also share misleading information or myths regarding vaccines, as is happening now more because we have also social media. So you have various, I would say infodemic being spread earlier about COVID, and now more importantly about vaccine, that, you will suffer this after effect. You will, there were also myths about that it will affect fertility in men. So you see this sort of myths being spread by social media influencers, families, peers. They also influence the hesitancy or the reluctance that is shown by people in taking vaccines. Robinson, recently I was reading, he writes about 5C model, which considers the following psychological factors that affect vaccine hesitancy. So first he says confidence, the person's trust in the vaccine efficacy and health and safety, the health services offered to them, the policy makers deciding on the rollout. And we are not the only country facing this hesitancy, mind you. Scott Ratson and others talk about the US experience. They said that when a survey was done of unvaccinated respondents, it revealed that 1 in 6 said that they would be more inclined to be vaccinated if their health care provider recommended it to them. Thankfully, in our country, our vaccine program traditionally and for COVID vaccine rests on our primary healthcare system and also on you see hospitals that people frequent to. So therefore, that part is a little, taken care of. Next thing is that, this COVID itself, we don't know much about it. And I'm very sorry to say that even after a year, we do not know much about the mutations that are coming up. We don't know how the waves are coming up. Of course, we know that COVID inappropriate behavior is something that we need to avoid to ensure that because we are responsible for our own health. But you see, we don't know what's in store for us. So that way, this is an unknown enemy that we are fighting with. So therefore, the confidence level is a little less, which we need to address. Next, of course, is complacency, whether a person or considers the disease itself to be serious or is it a risk to their health. And you must understand here that the fertility rate in COVID is low, but the impact is enormous. So therefore, this is again in our strategy to talk to people. We need to talk about the overall impact that is happening also. Next is calculation. The third C. It is the individual's engagement in extensive information searching to weigh up the costs and benefits. Then the constraints, is it easy for him to access the vaccine? Is the supply there? Dr. Ghosh cited that, one of his relatives had to visit another center because the vaccine supply was not available. So you see the dependability, the accessibility to the vaccine needs to be ensured. Therefore, the supply side is also very, very important. Then, of course, the last C is the collective responsibility. The willingness to protect others from infection through one's own vaccination. So these 5 C's are important, and it also must be understood that vaccine hesitancy should be addressed by closely monitoring and addressing issues at the community level. In India, as was pointed out, we've had issues of vaccine hesitancy effectively tackled both for polio and MR campaigns through advocacy with stakeholders, through community leaders, educational departments. You see, it is a whole of government approach that is required. And therefore, I'm not surprised that the learnings from these campaigns were aptly built in the COVID vaccination drive through a comprehensive COVID-19 vaccine communication strategy that is also there on Ministry of Health and Family Affairs website. I request you to look at it. Now the states have to work at it, the communities have to work at it, and more importantly, all of us have to work at it. So we need a clear, consistent, transparent messaging as envisaged in that strategy. That's what is required. And we need to address it through social mobilization, through community engagement, to build ownership and trust, because trust is again very, very important issue. In all the 5 C's that I listed out, trust was the underlying issue. Where there's trust, all those 5 C's vanish. And media is an important stakeholder. That is why the infodemic that is being spread has to be countered. So media, engagement with, also I feel that the radio jockeys, the TV anchors, all of them need to be sensitized. We had done it for Beti Bachao Beti Padhao scheme also, and maybe the same thing needs to be done again. And our experience with polio, MR, and Mission Indradhanush also showed us that the faith leaders can play a very important role in positively addressing hesitancy amongst their followers. They can become very important social influencers. And states like Arunachal, Chhattisgarh, Himachal, Jharkhand, J&K, Ladakh, Madhya Pradesh, Nagaland, Rajasthan, Uttar Pradesh have actually run targeted campaigns addressing youth, women, tribal citizens, medical fraternity, the healthcare workers, the frontline workers, through their community leaders, influencers, local champions, and faith leaders. We need to take this more vigorously. Recently, as you know, and Dr. The chair also pointed out that COVID vaccination has been recommended for pregnant and lactating mother, with clear guidelines for helping the pregnant woman and her family take an informed decision. So here, the role of the concerned gynecologist, the role of the doctor that the woman depends upon, the role of the community health worker she talks to becomes very, very important. So that is the pillar on which we need to work. And unlike many Western countries, you are aware that we have a huge cohort for vaccination. Our eligible population for COVID is many times over many Western nations. Actually, we've already vaccinated many Western nations, and we need to do many more. So as large population groups are being vaccinated over a short period with new vaccines, monitoring the safety of these vaccines is critical. We do have a very robust EFI surveillance system. And the recent study that Dr. Ghosh has quoted about the effect of vaccination in army settings, I think we need to talk more about it so that it builds confidence. And there is no other way but vaccinate, because if we need to lead normal lives, we come back to working on livelihoods of our country, we really need to address vaccine hesitancy together, and government alone can't. I think that's also to be understood. It is a responsibility of each one of us. And I was just wondering that we keep talking about vaccine hesitancy. You are all here as manufacturers. It's a manufacturers association. would you like to also see it from the angle of demand creation? I leave you with the thought. Thank you.
Thank you, ma'am. Very pertinent points raised by you, especially about supply and hoarding. You spoke about global good, about public good, about common good, about community good, and why everyone needs to work together. Your sentence about there is no other way but to vaccinate resonates very well with today's theme. You touched upon a very important point of trust, and you said that where there is trust, then everything else disappears, and you don't really have to motivate people because they trust you, they trust the product, they trust the efficacy, they trust the government, they trust the service providers, and therefore all other questions disappear. You also said that everyone, whether it's the common man, whether it's the policymaker, whether it's the politician, or whether it's bilateral agencies, everyone has a collective responsibility. It's no one agency, no one government, or no one individual who can make this happen. Everyone has to own the responsibility and come forward. And unless everyone owns the responsibility, vaccinating such a large population, and you also pointed out very rightly that vaccine hesitancy is not something that's unique to our country. It's a global phenomenon. In fact, you see this more often in the more developed countries than you do in a country like India. However, we have been able to successfully vaccinate quite a large population. And how do we then, actually reach the numbers that we want to? So dwelling on the point of collective responsibility, public good, and common good, I would like to invite our next speaker, Dr. Bhan, and he has had a lot of experience with various vaccinations. So Dr. Bhan, there are a lot of people who are educated, who know that the vaccine will protect them from serious, mortality and morbidity, yet they say that it is my personal choice not to take the vaccine. So if we had to debate about this collective responsibility, and no one is safe until everyone is safe, what is the message that we send to these people, and how do we make them from people who are saying that it's a personal choice whether to take the vaccine or not to take, to people who say, yes, I need to protect my neighbor and therefore I will come forward to take this vaccine? So how do we talk about the ethical part of choice versus personal good and common good and global good? Over to you, Dr. Bhan.
Sure. Thank you so much, Ratna and Dr. Ratna, and pleasure and honor to be on the same panel as Dr. Ghosh and Ms. Sudan. So I think this it's already been a great discussion, and you raise an important point around individual responsibility, public health, etc. When you look at vaccination, especially in the context of a pandemic, first we have to recognize that it's an important public health response to the pandemic, and this is something, hence, which has to be driven, of course, by the state, which is the government in this case, but also has to be supported by the public, so community members, because only if people come forward to get vaccinated will we actually reach a stage where there will be adequate coverage of the population, hence protecting a large segment of our populace. Now, the issue there is, of course, you need a mix of things. You need adequate vaccines to be available. You need those vaccines to be accessible to populations, and then you need uptake, right, which is the demand side issue, which we've been talking about. But here, I think it's important also to look at what might be some of the issues why people might be reluctant or have not come forward. And here, maybe I will take a slightly more critical lens than my two other fellow panelists. And the reason for that, I think, is that we have to acknowledge that while there has been a lot of success, I mean, as a country, we have done really good in terms of the volumes, the number of vaccines that we have administered, but our vaccination coverage as a proportion of our population still has a lot to improve. But the story of how the vaccines have gotten where they have gotten also is one where, of course, there have been issues and gaps that we need to acknowledge. For example, is the fact that our regulator has sort of been silent through this entire process. We don't really see the regulator go out and talk about vaccines, what are their mechanisms for addressing vaccine safety, what are the steps that they are taking, who's involved, why do we not have the kind of transparency you would expect from a regulator? And we've seen from regulators in the West, if US FDA discussions on vaccines can be live cast and we know who are the experts involved, why is it that we don't see that kind of transparency? Now, I don't say this because I want to criticize our regulator. I say this because this all adds on then to some reluctance around not feeling sure or feeling that there is something which is not known. So I think more transparency is something which we certainly need to encourage more of. And the second thing linked to that is that when we talk about vaccine hesitancy, we have to break it down a little bit, right? Because there will be some people who are probably opposed to any vaccines. That is the purest vaccine hesitancy movements that we see often in the West, lesser so in India, but Dr. Ghosh described already that have also happened with some middle class families, perhaps some religious communities, and that has been very effectively responded to by good quality community engagement in the past, and we must learn from that. But there are other people who probably had valid concerns or questions around vaccines, which were perhaps not responded to in an adequate manner. So I think the story there then becomes, how do we engage? Because people can have valid concerns and people might have questions. What does it mean to give it to someone with comorbidity? Should a cancer patient take it? Should a pregnant woman take it? And we talked about now that there is evidence available and there's more supportive information being provided. But that is the kind of communication which should be two-way that we need to see. What we see right now is a very didactic communication, very paternalistic in nature, which is driven by, here is the information, and of course we know what is right for you. So how do we make that public health communication to be more discussion focused, so that we have an ability to absorb any concerns which exist and respond to them? So I think that certainly is an important part. The second part, I think, is if there are concerns about safety, and those are totally understandable, because these are still vaccines which are largely within an emergency use authorization framework. In India, we're calling it restricted emergency use, which means that while right now, I think across the board, all of us would agree that there is a lot of information supporting the fact that these are very safe vaccines, because millions of doses have been administered, hardly any adverse events. That having been said, there is going to be the rare adverse event. And the important part here is to say, yes, there is a possibility of an adverse event happening. These are the kind of events we might expect to see. If you have such an event, we will very quickly catalog it, try to see if there is an causality, and then try to address it, right? And the issue there, I think, is that our AEFI workup, while we have an excellent system in place, is also something we need to make more efficient. And the reason I say it is, if you look at our AEFI assessments which have been done over the last few months, they've been delayed, right? So we get information, but we might be getting that information a few weeks too late as compared to many other countries, and I include low and middle income countries. So I think we need to also make our system more efficient, because if this is such an important public health imperative, then the systems attached to it, including on AEFI assessment, need to be more efficient. The other part is, I would advocate that we should be moving towards a no-fault compensation mechanism. We really don't need to be running around trying to figure out causality assessment, especially if there is a major adverse event which someone undergoes. And that is, again, something which the government can take on the onus for, because we always have this concern, and we are already seeing that with perhaps one vaccine, this whole issue around liability. Who takes on the liability if something happens? And as we discussed, that rare circumstance could be there. But the progressive way to look at it is there should be a social safety net. And if people are agreeing to come forward for a public health purpose, such as vaccination in response to a pandemic, then should something happen to them, the state will take care of them. And that would be the ideal situation. But we have not seen that, quite honestly, with polio as well. There is a small proportion of children, as we all know, who could get vaccine-associated paralytic polio, and we really do not have a program to respond to their needs. So that is a failure of a safety net, because again, polio is another example of a public health effort. So I think as a country, if we can figure out that, the cost of actually putting in that safety net is going to be minuscule compared to the cost of running such a large program, but that builds confidence in such a huge manner that the state is going to come forward and take care of us. That is the kind of step which would be required, because once you do that, once you build confidence and trust, which is what Dr. Ghosh and Ms. Sudan were also talking about, then I think it's much more likely that people will come forward, because then the whole ethical issue of should we be considering compulsory vaccination at all or mandatory vaccination. If you see today's Hindu, there is a lawyer who's written about it, because there's a court case, I think in a Meghalaya High Court, talking about the legality of compulsory vaccination. And of course, that's going to be an area of discussion. But in India, I don't think we have that situation. We have a lot of people now, especially, who are very willing to get vaccinated, but perhaps the supply constraint is still there, and the government is, of course, trying to fix it. So the concern around people being reluctant to take the vaccine is largely a small concern. but it centers around trust and community engagement. And there is a lot of lessons there. Dr. Ghosh has spent his entire career, has such a rich tapestry of experiences that he already described in his presentation as well to draw from. If the health system is available, if there is a two-way communication happening, there are mechanisms for concerns to be heard and responded to, I think we can address a large proportion of vaccine hesitancy, the true nature of it, very quickly. And I think we can certainly have a much more equitable ethical program if we just bring in concepts like transparency to be the center of how we respond to any public health issue, not just vaccination or a pandemic. So I think that's where I would like to maybe leave some space for discussions. I'm sure that's what we want to do for the rest of our time.
Thank you, Dr. Ban, and excellent points that you have raised about the regulator being silent, more transparent communication being more interactive and participatory and not just a one-way kind of a communication. Having a no-fault compensation or a social safety net mechanism that builds the trust amongst the people, that rare case that does have an adverse event is actually taken care of by the state or by the employer, some mechanism that tells them that you are not on the wayside if something happens to you, but there is a system that will take care of you. So excellent discussion so far. We've had such lovely points coming up. I have a few questions and I'm aware that we have another, say, 15-20 minutes. So ma'am, Sudan, ma'am, there is a question for you, and you raised this point about the trust in the doctors or the care providers and vulnerable populations like pregnant women and lactating women who would probably trust their care providers the most. And if the care providers tells them that the vaccination is safe for you, they'll not even question anybody else. They'll just go ahead and take the vaccine. So some of these myths that are there, and also, there are so many other vulnerable populations. So one of the myths that has been circulating around has been addressed through scientific journals and other articles have been that, people who are on blood thinners should not be taking this vaccination. For example, people with stroke or other neurological conditions. So you also raised this point about, how can the service providers or healthcare providers build the trust? So what would be your advice to people who have these conditions where they are not getting the right information from their service providers? Is there a system that can be built so that some of these people who are, who have a rare condition or who have some kind of a immunocompromised condition or who have some kind of a vulnerability are not going forward because they fear that something else might happen if they take the vaccination?
So, you see, my answer is twofold. First is you've spoken about a pregnant woman. Now, the gynecologist that she's showing, I'm sure, is fully qualified in assessing her condition and in guiding her. Because you see, it's not just her present condition, but it's also history of her pregnancies. And also she can guide on when the timing should be. So that's one. Next thing, you've spoken about other complicated cases. Now this, say a primary health worker cannot clear those doubts. It has to be by a specialist. So the mechanism has to be that, and if the person does not have access to that specialist, then whoever is the primary caregiver, whether it is in public domain or private domain, has to refer it to a specialist and then tell them that what is to be done. And this is a very important issue which has been raised. I think I will also informally take it back to the ministry so that they can have this mechanism in place. We've had during the COVID war, in fact, in the first wave itself, there is a igot.gov.in online training. I hope you have seen that website. It's a training for volunteers, for health workers, for youth, and anybody who would like to be associated in this war against the pandemic. So a new capsule can be added on vaccine hesitancy by for specific groups. So I'll take the suggestion back to you, and I suggest as a association, you also write to the ministry.
Thank you, ma'am. Yes, we will certainly take that suggestion back. So, Dr. Ghosh, coming to you, Madam Sudan referred to an infodemic and various, stratas of society that need to be addressed, whether it's the faith leaders or the youth or tribal populations, etc. Now, considering the volumes that we have and the kind of geographic spread and the, last mile delivery, even for information might be extremely difficult. So in your opinion, do you think digitization has a role to play in busting the myths and getting this information to the largest, number of people or to the farthest corner of the country?
Right. I with digitalization, I always have an issue about access because, I have really seen, this somehow, the privileged people have an access to the digital kind of resources that we have. And often, it does not reach the last mile. But what I really wanted to also do, take this opportunity because now I have the mic, is reiterate 2 points. So one point that Madam Priti Sudan had made around the trust, and I'll tell us very small anecdote, a short anecdote about it. And I want to double reiterate what Dr. Mahan spoke about, the quality of the surveillance and the involvement of the regulatory authorities. These are very, very critical elements that we really need to bring into the picture. We cannot survive with a weak adverse event following immunization surveillance because we need to capture those rare diseases. And that is a great area where, digitalization plays a very important role, because the delay that he spoke about is also very, very important. That if we have delayed information, it's almost like justice. Delayed information is actually no information, because by that time, a lot of bad things have happened in the field. Therefore, in order to speed up, we need digitalization. The short anecdote that I want to say is about in 2005, after the massive outbreak of Japanese encephalitis in eastern Uttar Pradesh, India introduced a vaccine in order to address the public outrage, public outcry, and because there was an acute shortage of vaccine in India from China. It was the SA-14-14-2 Japanese encephalitis vaccine, never tested on Indian soil except 2 districts of Andhra Pradesh, and that's a very patchy program in Kurnool and in Anantapur, very, very patchy program. Never tested on Indian soil. First time it was given to recipients in the campaign. We did not have data on safety. We did not have clinical data. What we had is the trust of the people on, and I am sorry, but I'll take the name because the current Chief Minister of Uttar Pradesh, who represented that part of, Uttar Pradesh at that point of time, actually came out and talked to public and said that, please go ahead. And this, kind of all the political leaders coming together, and what Madam Sudan was referring to, the Indian Academy of Pediatricians, the Indian Medical Association, they were all trained. They gave a written commitment that they would stand by the vaccine. And therefore, what happened, whenever the parents went back and asked these professional organizations, they kind of supported it. And a vaccine that had never been tested on Indian soil saw a coverage by UNICEF independent evaluation of more than 80% coverage. So this trust piece is very, very important. And when you spoke about digitalization, I do want to say that WHO has now launched the SafeVac software, which is a digital software where a health worker will be able to input the data on the adverse event, and it immediately reaches at the concerned level, I'll say state level and the national level. The SafeVac needs to be scaled up. The good news is that the Gavi Health System Strengthening Grant that is there, which is coming for India, will consider SafeVac as one of the components that they will try to strengthen. And I hope that, in a very soon, we will have a much more speedier, a much more, efficient digital-backed safety surveillance program in the country, which will in turn boost the confidence of the community for vaccination. Over.
Thank you, Dr. Ghosh. And taking forward from that, you touched upon trust. So my question is to Dr. Bhan, and I'm just picking up on this point that you raised about having a social safety net and a mechanism for no fault compensation. Now we also know that when there is an adverse event, it is not just the community that loses the trust, but the healthcare workers are also targeted, and therefore the healthcare workers are fearful of going into such areas, and consequently the vaccine program suffers. What are your thoughts on this? About this no fault compensation? Should it be limited to just the recipients, or should the care providers also have some kind of a safety net so that it is, like as Madam Susan pointed out, it is not just one department or one ministry working on this, but it's really a whole of country, whole of society kind of an approach?
Sure. So, I mean, the first thing is any kind of violence on any kind of health providers is not acceptable. I mean, for any society, I mean, that is just a no. You cannot be raising your hand. You cannot be beating up health workers. That it has to stop. Unfortunately, we've seen a lot of that during the pandemic as well. There are various trigger factors. Of course, we need to address those as well. Partly, as you are saying, trust is an important element of it. But beyond the conversation around how we respond to AEFI's compensation is a larger issue. And the larger issue is around the fact that, you cannot have the vaccination as an island of excellence, which is to say that there are many communities still in our country which have not been touched by the health system in a proper manner, right? So if you go to those communities and you only offer vaccination, in this case, adult vaccination of the scale which has never been done before, and yet you don't respond to some of their other concerns. And Dr. Ghosh did mention this as being one of the primary drivers of reluctance around vaccination. If they've never seen your health workers before, if they've never seen the kind of outreach that you are seeing during a vaccination, of course they'll have questions. They'll say, they will have concerns around the fact that there are so many other public health issues, but you never came to us and you never addressed those, including pregnant women, for example. We have one of the largest maternal and child health programs, but we still, as you all see on a regular basis, have pregnant women having to be carried for kilometers and for hours just to access maternal care, right? So that is the larger picture issue that, at the heart of it, beyond the conversation around AEFIs and compensation, is a truly universal health system. And when we get there, I think that is where we will start seeing much more trust building. So of course, we need to work on AFI and compensation, and we need to ensure that there is more transparency, but we also need to make sure that we learn from the pandemic. If not now, then when can we expect to have a more resilient, stronger, well-resourced health system, which is accessible for everyone? And if we work on that, then of course, all of these would be integral elements of that. But that is the larger picture we all need to remember. And everyone has a role to play, including, all the members of OPPI, because they're, of course, integral to our response as important providers to ensure that we get that kind of a health system.
Thank you, Dr. Bhan. Resilient health systems, that resonates every time we have a health emergency, be it a pandemic, a natural disaster, or a man-made disaster. And I think that is the bottom of, bouncing back and giving the health care that people deserve. So I'll just take a couple more questions before I round this up. And this question is to Madam Susan. And ma'am, you referred to a lot of mutations happening, and basically the scientists and the policymakers batting in the dark and still being able to overcome the challenges that are there. Now, considering that the vaccine is mutating very fast, and many of our vaccines are able to manage these mutations, but going forward, do you think that COVID-19 vaccination will become part of a national immunization program? Will there be boosters? Will there be other vaccines that need to be taken, or will it continue as it is?
Well, I have a counter question. Why haven't we come out with a drug till now? We've come out with vaccine. Why isn't there a drug yet? So I think we all, especially you manufacturers, need to work on the drug too. And yes, of course, we see the mutations again. You see, we do not know much about this disease even now. There are studies going on booster dose. There are studies going on whether we can take the vaccination to children now. As you know, their co-vaccine is being tested on children. So all these are, nobody can predict in a manner which is definite, but we have to see how it plays out. But I think as very respectable manufacturers and very dependable manufacturers, I'm very proud of our pharma industry. We must look and work on a cure. I think that research has to be a little more on that. Thank you.
Thank you, ma'am. Very well said. And this is my last question, and I'm addressing it to Dr. Ghosh for no particular reason. There is a question from the audience which says that there is this myth, amongst the general population that if you get fever after a vaccine, then that is a good sign that you have developed an immune response. And therefore, people who do not have fever are a little worried that the vaccine is not working on them. Is this true? And how do you counter this kind of a myth?
I would really say that no, there is no relationship in terms of fever with the vaccine. There are some who develop fever. There are many who I know have not developed fever, but are protected from the disease in case of childhood vaccination. In case of adult, COVID vaccines also, there is a strong discouragement both by, US and in other countries about testing of any kind of antibody titer after the vaccination, because these don't give any kind of relevance in terms of the protection of the individual. Therefore, I'll say that, the fever has nothing to do with the vaccine, but generally that is a common symptom that we see after vaccination. There is nothing to worry of mild fever. If the fever persists more than 48 hours to 72 hours, then one should consult one's physician. Other than that, simple paracetamol tablet as advised by the healthcare worker is fine.
Thank you, Dr. Ghosh. And that brings us to this wonderful discussion, end of this wonderful discussion today. Some of the key takeaways are, of course, the whole of country, whole of society approach. No one person can achieve the numbers that we want. No one is safe until everyone is safe. Trust has to be built. There has to be no fault compensation so that people are not blamed. Dr. Ghosh, I will highlight the partnerships planning and the patience to hear part of your message that you came across, that you gave to the audience and to the rest of us. So thank you so much to all of you, and I hand over to Asavri now to give her closing remarks.
Thank you, Dr. Ratna. Thank you to this wonderful panel, actually, for such an insightful and engaging discussion. The deck that Dr. Raj presented, the discussion on the 5 C's from Madam Sudan, I think trust really being the underline of it all, as highlighted by both Madam Sudan as well as Dr. Bhan, and really how ethics and transparency can help in achieving the results, as again spoken by Dr. Bhan. I think it has been a wonderful and timely discussion to add to that. And I'm sure we'll have a lot of takeaways from this discussion as well. Very well moderated by Dr. Ratna Devi again. And thank you so much to everybody present. I hope we've been able to answer most of the questions from our participants. And I thank you all again for the discussion, and I wish everybody a wonderful and a safe weekend. Thank you, and we can close the discussion for now. Thank you so very much.